Well, I think it is on the schedule here for me to talk to you about echocardiography, which is ultrasound of the heart, the window to the human heart. And I don't have to even ask you because everybody knows what echocardiography is about. It is using ultrasound to take a look at the heart. But it is really amazing that over the years, this simple principle of sending a little ultrasound wave and getting them back from the chest can give you so much more information than just seeing the heart and seeing the heart move. Because what we've added over the years is Doppler. You hear about Doppler. And with Doppler, you can tell what the velocity is like of blood within the various chambers, and from that understand also by using some principles, Bernoulli principle, what the pressure gradients are within this heart. And you could look at color Doppler, just see it right there as to where if there is abnormal flow, there are jets in there, there's regurgitation. So you can tell so much now from the same principle that we've had over the years. So this has really been an amazing evolution since the inception of ultrasound back in 1950s. And the interesting thing is, among all these imaging modalities that we have nowadays, it is the one that can be miniaturized. So you know now you can have the large machines that give you all the information that you need, to the pocket ultrasound that many of the nurses, nurse practitioners can use, and even the physicians can use. And I think if bundled system come on board, et cetera, you're going to see many more individuals using them at the bedside to try to answer a very quick question. Is there a pericardial effusion? What's the heart like in function? It can be used in the emergency room. So many other things that the bigger advanced imaging may not be able to tell you. All right, so I know most of you know what we are talking about here. So in this 15 minutes, I'd like to share with you some of the things that you really need to know if you're the ordering physician or you're a nurse practitioners. What do we use this for? Almost anything related to the heart, indeed, because it's not invasive. It doesn't have any radiation, doesn't have any contrast the way we think about it as toxic to the kidneys, etc. So it can be used, and at times, unfortunately, overused. And I want to caution you about the good uses, but also some overuses. You can't order this for a headache, right? Although we've seen some of that. Evaluate chamber size and function. So if you've seen something on the chest x-ray that is, the heart may be large, let's take a look at the dimensions. So yes, you can get dimensions with it. You can look at heart function. And it's not only the left heart, the right heart, what the atria are doing. Evaluate the presence and severity of valve lesions, pericardial effusion, atrial fibrillation nowadays much more than ever before, because you look at function, size, appendage, is there a clot, and we'll talk about TEs, endocarditis, stroke, and aortic dissection. So almost pretty much anything. The other thing is, most of you order a transthoracic or surface echocardiogram, the probe put on the chest. However, you know about a transesophageal approach, right? A transesophageal approach. Why? Because now you bypass the lungs and so many other things, so your visualization is so much better. That's number one. But remember, that visualization is pretty much for the base of the heart. The atria, the two of the valves, the aortic and the mitral valves, and the left atrial appendage. These are the big things, really, and the aorta that a transesophageal can tell you. So TE is better resolution, more effective for basal structures of the heart. So at times, actually, a surface is even better. For evaluation of ventricular function is better, for a tricuspid valve, pulmonic valve. So TE is not the answer for everything, and I think you need to keep that in mind. Ventricular function is still the vast majority of utilization of echocardiograms. Tells us about the left heart, and you could see a normal heart here, really nice, squeezing every time the heart contracts. And at the same time, we can take a look at the thickness. Somebody with hypertension, what is the thickness of this heart? LV mass, LV ejection fraction, a word nowadays that is ubiquitous. If everybody talks about an LV ejection fraction, which has prognostic information. You hear about 3D, and that's already integrated in your order. So you don't have to order a 3D separately. So we use it depending on the situation, which foregoes all the geometric assumptions that you have to deal about the heart. One thing at times that you hear about is strain imaging. And what strain is is basically look at regional function of the heart. You could see it very nicely on the top, a normal heart. On the bottom, somebody had a heart attack with almost an apical aneurysm. You could see it there. And it basically tells us what is the thickening of this heart in one dimension. So you hear about global longitudinal strain. It's almost like thickening fraction, but it has a negative number. And the reason why, because the heart is shrinking here, and more negative than minus 18% usually is a normal thing. It's used quite a bit in cardio-oncology, where you're trying to detect early depression and ventricular function in individuals getting chemotherapy that may be toxic to the heart. So, indications, common scenarios, recent myocardial infarction, chest pain. A resting echo is minimal value unless you're suspecting something, suspecting pericarditis, something that is that can be revealed by a resting echocardiogram. But that's like Mike Quinones told you, if you're looking for ischemia, for somebody who has exertional chest discomfort, a stress echocardiogram certainly is better. Dyspnea or heart failure, an abnormal electrocardiogram, time to see what the heart is like, cardiomegaly by chest x-ray, systemic hypertension, cardiotoxic drug we just talked about, prior to major surgery with suspected heart disease. However, that has a particular indication. Not all patients need an echocardiogram prior to non-cardiac surgery. So for chest pain, acute MI, pericarditis, aortic dissection, hypertrophic cardiomyopathy, particularly if you have a very abnormal electrocardiogram. Okay, well, you don't have to be an echocardiographer or cardiologist to figure out that these 4 panels show different hearts. And these individuals have symptoms of heart failure, mostly shortness of breath. Left upper is a hypertrophic cardiomyopathy. The one on the right upper, dilated cardiomyopathy. The heart is really poorly contractile and very large. Left lower, it looks like an infiltrative heart, amyloid heart disease, or a burned out hypertrophic cardiomyopathy or hypertensive heart disease, very thick myocardium. On the right side, the right lower, is a individual with a previous myocardial infarction. You could see the septum not thickening at all, and the other areas are better. So just imaging can tell you, in a patient with heart failure, can tell you a lot about what the underlying mechanism is. This normal ejection fraction, heart failure, versus abnormal ejection fraction. Can tell us about hemodynamics. We can estimate what pulmonary pressure is like, and prognosis. And this is 20 years, believe it or not, an anniversary from Dr. Naga, from our group right here, who developed this way of interrogating or understanding what the filling pressures of heart. If somebody has dyspnea, is this left heart failure, yes or no? Using Doppler techniques of how does the ventricle fill and what's the tissue Doppler of the tissue is like. And then a ratio of these two can tell you a lot about pulmonary capillary wedge pressure, which tells you about filling pressures of the heart. And that's basically in the guidelines now, used all over the world. You can see in the reports that you can get PA pressure. And how do you get it? Is you get it from this little tiny tricuspid regurgitation jet that is prevalent among most of us here, and this is physiologic. We use a Bernoulli equation, do a 4v square of that velocity, and add an estimate of right atrial pressure, and that's how you can get a pulmonary artery pressure. You can enhance it with contrast, but if you're interested in what the pulmonary pressures are like non-invasively, this is really the way to go. Pericardium, very important actually among the earlier applications of what ultrasound is about. You could see a small pericardial effusion around this heart here. And I think this is important, obviously, if you're looking for cardiac tamponade, which is a clinical diagnosis, post-op, metastatic cancer, somebody with viral pericarditis. Remember one thing, you can have pericarditis with ST elevation, diffuse ST elevation, without any fluid. So it's just an inflammatory process that gives you the electrocardiogram. Yes, you can have an effusion, but not necessarily. So if you can have pericarditis without a pericardial effusion, remember that. I think this is very important from a clinical point of view. So let's see if we can advance this. There you go. There's a little lag. Okay, valvular heart disease, big application of ultrasound, and actually it is still the preferred methodology to look at valvular disease, be it valve stenosis or valve regurgitation. Here in the regurgitation, you could see, if I can advance this probe here a little bit, you could see some of these leaky valves by color Doppler. You could use other technologies to try to understand what the gradient is like through. And these are the common scenarios for you. If you're an internist and hear a murmur, this is what you need to do unless you feel comfortable that it is an innocent murmur in somebody who's young. Somebody with known heart disease, known valve disease, you need to know timing of an intervention, be it surgery or catheter-based procedure. Serial assessments, I think, is very important. And all these patients that get prosthetic valves, I think this is really the way to follow them. Endocarditis is a big thing. You could see this big gumba there, right? It is a large vegetation, and then you could use 3D echocardiography to try to understand how extensive it is and where does it go. Now, for you internists who are following patients, you don't need a transesophageal echocardiogram all the time. If you have good images on the right side and you have a positive surface echocardiogram without complications, you can stop there. But if there are complications, there are fistulas, there are some other things, you may want to do a transesophageal echocardiogram because of its higher sensitivity and resolution. If there are poor images, most of the time the echocardiographer will advise you for a transesophageal echocardiogram to take a look at that. Patients with strokes, particularly with previous infarction, can have what you see right there, thrombi, particularly in the apex. And for individuals with atrial fibrillation, I think it would be very important for them to undergo a transesophageal echocardiogram because this left atrial appendage, where most of these thrombi reside, cannot be seen by a surface echocardiogram. They're too much in the base, too far away, and you need a transesophageal echocardiogram nowadays. So you see most of the time before a cardioversion, a transesophageal echocardiogram is done. How about non-cardiac surgery? These are class 1, 2, and 3. 3, remember, is not indicated or could be harmful. There's no harm here in echocardiography, but you don't do this. You shouldn't do this routinely. Cataract, even non-cardiac surgery that is significant, cholecystectomy, I mean something else. If somebody is active, physically active, has a normal electrocardiogram, has no symptoms, no heart failure, an echocardiogram is not needed. And I think, unfortunately, that's quite a bit of the time still ingrained in most individuals. Yes, patients who have heart disease need it, certainly, or symptomatic, and I think your judgment is beyond an echocardiogram, should they be tweaked or managed appropriately before they undergo surgery. I think that's going to be very important for you going on. It is a changing world. And I bring this because this is not the science of medicine, this is the practice of medicine. I can get an echocardiogram on each one of you. Is this appropriate? Is this cost effective, right? We want to do the right thing for our patients, right? But we don't want to abuse the system, particularly if each one of you had to pay by pocket, the $300 or whatever it is, $400 that you're going to do, right? So you could see the constriction around the chamber over there on the right side, and it is about to change again, but irrespective of your politics and who's ever there, the changes that have occurred already, meaning putting the value equation on what we do, is already there. And actually it was before President Obama was there. And the reason for it was because of what you see right here. Okay, what you see right here is utilization of imaging, and echo is about the same. Utilization of imaging over time, which has increased significantly, much more than a progression of the disease process or detection of new diseases. Yes, we were not using CT and MR and echocardiography and TE for atrial fibrillation, before this, but it is not sustainable. And I think it's important for us to think about it. And that's why ACC, along with industry and so many other professionals, came up with the appropriate use criteria for us to say, well, what is a test appropriate? This is almost a translation of the guidelines and pertains also to echocardiography. So if you're interested, this was published in 2011, and it's really not much different. An appropriate study is one in which expected incremental information combined with clinical judgment, which is still important, exceeds the expected negative consequences by a sufficient wide margin. So the procedure is considered generally acceptable, and there is a panel for that. So when is an echocardiogram not cost effective? Routine checkup. Somebody completely asymptomatic and said, doc, check my heart. And you check it out. Well, if you have a normal examination, no murmurs, a normal electrocardiogram, and have nothing else, no hypertension, don't need an echocardiogram. Now, at times patients feel better if you do testing. It takes more time to stop a test than order a test, but I think it is our duty, part of our healthcare system. Ambulatory patients with recurrent chest pain and no specific abnormality on anything. Patients with palpitations, they have nothing else. I mean, everything else is completely normal. Somebody comes in with, doc, I have some chest pain right here. Every time I breathe, it really hurts right here. You don't need an echocardiogram. This is costochondritis, right? The echo will be normal. And there may be a little piece of calcium there on the echocardiogram that has nothing to do with the symptom of that individual. So think about what is the diagnostic, importance of that. Elderly patients with stroke in whom anticoagulation is already indicated, and you're looking for atrial fibrillation. Think about if the test will change what you're trying to do. An innocent murmur in a young asymptomatic individual. So, few things. Always think about the pre-test likelihood, estimate of likelihood of disease, and know what specific information you're looking for, and how will the results, importantly, alter your diagnostic workup and management. If it's not going to alter it at all, just don't do it. If somebody's atrial fibrillation had a stroke and you know what the ventricular function was a couple of months ago, you don't need to repeat another one. So, and the big thing really is the repetition. Somebody has heart failure or has a tiny murmur that is not significant. You've done an echocardiogram. You don't need to keep repeating them unless there is something different. The murmur has changed, or clinically they're different, and so many other things that will. And be order sets. If the echocardiogram is part of your order set, be careful of when to use it. Not all the time. Know the limitations of the test you're ordering. And if you're in doubt, we're here. If I want to get a radiology test and I don't know actually the indication whether I should do a CT or MRI, I call a radiologist. And if you're really not sure whether you need an echocardiogram, an MRI, a CT for the heart, a stress nuclear versus stress echocardiogram, we're here for you. And this is the team here at Houston Methodist. Dr. Shah, which is on my right side, he's the head of our cardiac magnetic resonance. This is Dr. Mamarian, who you'll hear from. Mike Quinones, you've seen, and where's Dr. Naga? This is the head of the Echocardiography laboratory. And we have wonderful faculty. We're here for you to help you navigate this at times, confusing landscape. Thank you very much for your attention.